I'm Dr. Bitan, and I've been working for 8 years at Lenox Hill Hospital. I'm the chief of spine surgery over there. For some reason, I decided to move out of the hospital. I'm still the chief of spine over there, but I'm just going to move to this office, which is a new place. We're just moving in, and we're going to start these lectures, which will happen on a regular basis. And people are welcome to come and educate themselves. We try to keep it at a level where patient could get instruction out of it. Basically at the level where we keep it for our patient during consultation. Okay? So the first topic I chose to cover is, sounds like a barbaric name, it's the Sacroilliac syndrome. This is the most uncommon problem. This is a very unknown problem, and actually most patients don't know about it, but to tell the truth, even most doctors don't know about it either. It's a very uncommon thing. And you're going to see in the quick presentation, we're going to have a quick presentation, and then if you have questions, if you have x-rays, whatever, we can all discuss it. So what is that? Basically, it's one of the reasons some people have back pain. So a lot of people have back pain. I have back pain as I'm speaking now. So everybody has back pain. And the reasons are very numerous. And the main problem of a doctor when a patient comes with back pain is to try to identify the cause. It's like somebody would come with fever, for example. So you don't treat the fever. You have to find the cause of the fever in order to treat it. If you just treat fever, you don't do any good to the patient. Back pain is the same thing. You have to figure out. And back pain is very common. 85% of people have low back pain. And this is one of the most common problems actually in the country. And the cost is astronomical every year. This is what's cost between the consultation, the medication, the different treatment, the surgery, whatever. So this is a serious problem. Most back pain are due to a spine problem. And in the future lecture, we're going to talk a lot about other causes of back pain. But I wanted to start with the most uncommon, which is sacroiliac. What is sacroiliac? Just a quick anatomy review. This is the head, the spine, okay, is here. But your spine, you know what your spine is. The spine has to be attached to your body somewhere, otherwise it would fall down to the floor. And where? How is it attached? By the sacroiliac. Basically, this is the bottom of your spine, and the sacroiliac is where the spine attached to the pelvis. On both sides, you have one here and one here. That's what the sacroiliac. We call it sacroiliac because it's sacrum, sacro, and this is the iliac bone, sacroiliac. Okay. Oh. So you see it here, spine. And here's those two joints on the side. You see that? Yeah.
That's the place.
Yeah, that's the place. You're right. The problem with this is when you have pain because of this, look how close it is to the spine. I mean, the spine is here, sacroiliac is here. So basically, the pain that's projecting, the patient basically says, I have pain here. For the doctor, it's very hard to know what is the cause. It could be this or it could be that. So where is it? This is the spine, and here's the iliac, and the sacroiliac is behind these ligaments here. Why do we have those ligaments? Very strong ligaments, one of the strongest in the body. Why is that? First of all, because, as I said, that prevents the spine from falling down on the floor. I mean, so this ligament has to be strong to hold it. But there's another reason, is that, and it's the most interesting reason, is that we don't need this joint to move. As opposed to a knee or a hip, we need them to move, to walk, to live. The sacroiliac, we don't need it. Who needs sacroiliac? This joint doesn't move normally, basically. So why do we have it? Usually, you know, in evolution, whatever we don't need disappear. For example, when we were animals, we had a tail. We don't have it anymore because we don't need it. Why do we still have this? For one reason, is that the pregnant woman, to deliver the baby, need the pelvis to open in order to deliver the baby. So there's only one time in life where women need it, is to deliver a baby. That's the reason probably why in evolution we didn't lose it. Otherwise, we wouldn't be here tonight and there wouldn't be any sacroiliac problem. Now, if this joint moves more than it's supposed to move, and that's why pregnant women have a lot of back pain, when it moves more than it's supposed to move, it creates pain. Because when you look at a CAT scan, we're not going to go into detail, but it's not a smooth joint like this, like a hip or a knee. It's like a tortures, a lot of things, and basically the minute it moves, it's almost bone against bone, so it's painful. Pregnant women have a lot of back pain because of this. Another thing you have to remember, and this is important because patients usually go to the doctor for back pain, but sometimes, and that's a trap, they go to the doctor because of leg pain, like a sciatica. And so everybody thinks, well, sciatica comes from the spine, it's normal. No. Look where the nerves are. All these nerves here, traveling from the spine down to the leg, look what they cross. They're very close to the sacroiliac. So if you have an inflammation of the sacroiliac here or here, those nerves could be inflamed, give you sciatica problem. And this is a big trap because if you take an MRI of the spine at this point, you're going to see, if the patient is more than 30 years old, you're going to see some bulging disc, you're going to see some this and that. And it's very easy to jump into the conclusion that the patient has a spine problem where it's not true. The patient just had this. So they have to be very careful. It's a big trap. So why do people have sacroiliac problem? One of the most common causes is degenerative, is just getting old. And basically getting old means that the ligament become a little loose and basically the joint start moving. Remember, this is the opposite of any other joint in the body. If it starts moving, it hurts, as opposed to other joints. Trauma is very important, very typical. Basically, look, this is a vertical joint. It's like this. It's not like a knee like this. It's a vertical, which means that if you fall on your behind, the force here going to bang into the bone, and that can disrupt. We call that a shear force. They can disrupt the ligament. So there's two typical mechanisms. The first one is to fall on your behind. The second one is a car accident. Why car accident? Because when you have a car accident, the first thing you do at the time of the impact, you press on the brake. That's a normal reflex, normal reaction. Even if it's useless, you still do it. And what happened? You have the foot on the brake, you have an impact, all the force go up your leg, same thing. Go up your leg, boom, and it disrupt the ligament. Fall on your behind, car accident with the foot on the brake. These are the very typical mechanism. Pregnancy, I already tell you why, because of the motion of the thing. Lumbar fusion. When somebody has, I don't know, you know what a lumbar fusion is. When the surgeon blocks the spine with the screws and stuff, what's happening? The patient continues to live, but then when the patient moves, the motion has to occur somewhere. And basically, it's putting more and more stress on the sacroiliac. And that's one of the reasons when patients have a lumbar fusion, it's very typical 7 to 10 years later to have a sacroiliac problem. Inflammatory arthritis is less common. It's more like a disease, like rheumatoid arthritis. That's a rheumatologist stuff. And those people, they're born with a disease, and they have sacroiliac problem. We don't see those very often, but it's possible. Anybody who has a sacroiliac problem who is young, no trauma, no pregnancy, I think we should get some blood tests, make sure this person doesn't have this type of disease. So look, the pain of the sacroiliac is here. And it's very typical. It's very low. If somebody has pain here, it's not sacroiliac. It's very low, and it's not in the midline. It's on the side slightly. Okay? So that's one thing that should alert us. The symptom can look like a sciatica because I showed you the nerve before. The pain here can travel down the leg, and everybody think of a sciatica, but it's not. It's only because the nerve gets inflamed close to it. Difficulty sitting because when you sit, same thing, you move the sacrum and the... Now, there's a problem. The sacroiliac business has kind of been rediscovered recently. And it's funny that this is a joint that until recently nobody was really interested in because you had the spine surgeon, they only do spine surgery, and the hip surgeon, they only do hip surgery. But it's just in between, the spine and the hip. But nobody was paying attention to that. And unfortunately, we've seen cases where patient has spine treatment, spine surgery, when it actually was a sacroiliac problem. Or a patient who had hip surgery when it was actually a sacroiliac problem. Now we start to understand better how to differentiate all these patients. So how do we diagnose this? We don't have a typical imaging for sacroiliac, and actually the diagnosis is mostly clinical. You can always do X-rays, CT scan, MRI. This can help a little bit, but that's not how you make the diagnosis. The main diagnosis is where the pain is, examining the patient. You see more and more doctors now, they don't examine the patient anymore, just sit here and then they look at MRI and CT scan. It works for most pathology, but for sacroiliac, it doesn't. You can forget about MRI and a CAT scan. The main thing is to get the patient undressed and examine the patient. Old-fashioned, 19th century medicine. Then you can do a provocative test, which we will talk about later on. All right. Basically, you find the pain here. So look, this is the back, this is the buttock. The pain is low, but it's not here. If the patient put the finger here, you know it's most likely not sacroiliac. If the patient put the finger here, slightly it's like less than an inch on the side, it could be sacroiliac, but it could also be spine. So it's not easy. We don't have an easy job, you know that. So you press, and if you can, the doctor can reproduce the pain by pressing on the sacroiliac, then you already have an argument that it could be the problem. Then there's a lot of tests. So I'm not going to go over this because as a patient, you don't have to know this. You just lay down and you do what the doctor says. I mean, that's it. But we have those tests that help us understand where your pain is. Because if you just press on there, whether it's spine or sacroiliac, it's going to hurt anyway, so it's hard to know. Those tests are a little more specific from sacroiliac. But remember one thing very important. A lot of patients, especially when they have a degenerative sacroiliac problem, they also have a spine problem. So the pain comes from two areas, and it's very hard to decide which one should have priority for treatment. Maybe I want to have Dr. Gonya talk about this.
Good afternoon. Dr. Gary Gonya. I'm also a spine surgeon that sees a lot of the same exact sort of symptoms that Dr. Bitan's been talking about. What Dr. Bitan has obviously explained sort of where the pathology is coming from, how we can try to localize the pain. But one of the big features of diagnosing this problem ends up becoming a diagnostic injection. Some of you guys may have been even familiar or have had injections with pain management. Often, obviously the goal there is to take pain away. But when we do these injections, obviously it'd be terrific if we can get the pain to improve or completely eradicate the pain with an injection. But when we're doing the injection, we really want a diagnostic injection. This has to be a feedback that we're in the right spot. Because as Dr. Bitan has said, clinically, this is, our back can give us a real, it doesn't necessarily give us a roadmap every time where exactly the pain's coming from. So what an SI joint injection means, very similar to an epidural steroid injection that is performed, which is the more common injection. You're positioned lying on your belly. Sometimes we can actually give some anesthesia. The anesthesiologist is actually there giving you some sedation, making you feel more comfortable. But it is a injection that is not exceedingly painful and can actually be done under local anesthesia, just a local numbing up the skin area. The thing is that we can't do this in a normal sort of office setting, is that we need fluoroscopy. We actually need, when that basically means is a mobile X-ray unit to be able to really localize where the needle is to confirm that we're in the sacroiliac joint. So it's a relatively, it's not a very time dependent or relatively short procedure. And the biggest thing, as this last bullet is pointing out, is that we really need, and we encourage the patients that this is something that you almost have to go and try to, not aggravate it, but go back and do your normal activities that really bring on those symptoms. So for those particular first couple of days, we want you to sort of test drive this injection as much as possible and really see, hey, this is when I sit for greater than 15 minutes or when I walk for 3 more blocks, this is when my pain usually kicks in. And with this injection kind of on board, all of a sudden, hey, those symptoms aren't happening. That's a big sort of feedback for us that we're zeroing in on the right spot.
After you make the diagnosis, then you have this injection, and if you have a significant relief from this injection, then it's like a strong argument that this is your problem. But you have to tell the truth. If you don't tell the truth, you have the wrong treatment, and that's not our fault, that's your fault. So you have to really understand what it is, and you have to tell the truth. You don't want to please the doctor or whatever. But assuming this is your problem, there are many layers of treatment. And I like to tell my patient that there are 3 layers of treatment. The first layer is to be totally non-invasive. Rest. For example, if somebody falls acutely and have pain, just rest. Take some Tylenol and just rest. Usually it's fine. If it lasts a little too long, then you use non-invasive treatment. And I like to use acupuncture. And actually, if you have a question about acupuncture, Dr. Fan is here, and she's doing my acupuncture. And physical therapy. We have a physical therapy representative here who you can ask questions. This you combine the way, I mean, it depends. Different ways to combine those two, but at least you cannot hurt. This is safe, and the worst that could happen is that it doesn't work, which is fine. You can go to the second layer of treatment, which is having sacroiliac injection, like Dr. Gonya described, but now not for diagnosis, for treatment. So you do a series of 2 or 3 injections, and then you can repeat them 6 months later, and you can combine this with acupuncture, with physical therapy. You try this. There's other thing you can do. I notice that chiropractic treatments sometimes work for acute event. You wake up one day, you can't move, then the chiropractors sometimes are pretty good at this. For chronic treatment, I never found it very, very useful. I could be wrong. I should have invited Sean Cotter, who's a chiropractor that I use. Maybe he could have had a different opinion, but that's my opinion. Sometimes it's nice to have a little pelvic belt. This is like a back brace, but very narrow and really pressing on the sacroiliac. That gives a little, everything helps. And actually my experience is that at this phase of the treatment, combining the different treatment is actually the best treatment. You have physical therapy, the rest, put the belt, do some acupuncture once, twice a week. If you combine all these things, it works better. Now, there are acupuncture. So it's an ancient traditional Chinese medicine, but this has been recently validated by modern research. There are a lot of articles now showing that it does work which we didn't know a few years ago for sure because it was only based on anecdotal reports. Basically, from what I understand, I'm not qualified to talk about acupuncture, but what I understand is like a more global approach. It's not like you fell, you hurt your sacroiliac, and then you fix your sacroiliac. This is a more global approach to the problem, which I'm not sure I understand everything, but it works. The main thing is, for somebody like me, that there's no side effect. I mean, at least as opposed to other treatment, like injections sometimes, steroids, you can have side effects from steroids. This is no side. I copied this from a book. Don't ask me what that means. But maybe if you have questions, maybe Don tells you something. I have no idea. We'll talk about this later. This is a little belt that we can use here. Why the breath works? That's very basic. As opposed to acupuncture, it's very complicated to understand. The belt is easy. I mean, your joint moves too much, stop moving, so it feels better. So it's very basic to understand, very easy. Physical therapy. Why would physical therapy work? Doesn't make sense. Because we say this joint is moving too much. All of a sudden, you physical therapy, which is going to make it move more. How could it make it feel better? Maybe you can correct what I'm saying, but I think by reinforcing specific muscle that stabilize this joint, the ligaments are loose, but if you train some muscle to become stronger, you can probably stabilize more. So you're not trying to get more movement in the sacroiliac, that's the opposite. You try to get less movement by strengthening some muscle. Steroid injection, that's what Dr. Gonya said, but what he talked about was mostly injecting a local anesthetic as a test. This is more like a treatment, steroid injection, to reduce your inflammation and to give you, usually that works. The problem is, in a lot of cases, the effect is temporary and the pain comes back after a while. You have to repeat the injection. And even though the doses are very small, after a while, it adds up and you have a lot of steroids in your system. And if you, for example, if you have diabetes, it might not be a good thing to have too much steroids in your system. So sometimes there are some side effects that you have to be aware of, and you have to monitor that. What is that? Radiofrequency ablation. Very quickly, when you have pain somewhere, whether it's a tooth, a foot, a spine, a shoulder, why do you have pain? You have pain because every part of your body has a little electrical connection, just like the lamps here, that goes to your brain. And when something's wrong, something beeps in your brain and it gives you pain. So you have two choices. Either you fix the problem, if you cannot fix the problem, you just cut the little nerve that goes to the brain and you don't feel the pain. Very simple. Again, nothing to do with the complexity of all the treatment. It's simple. The nerve that brings the pain, you cut it or you burn it. That's what it is. You burn the nerve, the little nerve. We're not talking about the big nerve that goes to the leg. Huh? The small nerve that gives you the pain that goes to your brain, you just burn them, and that gives you.
Does it stop the pain?
Yeah.
I mean, it stops the pain, but are you still doing damage? You know, you don't feel it.
Yeah.
Are you still doing damage to
Yeah,
it?
the answer is yes, because if we're successful and the pain goes away, then you're going to do more activities. And by doing more activities, you're going to create more damage. But at least you have no pain. And also, having a damage of this joint is not a big deal. You don't need this joint anyway. It's not like a knee that you don't want to damage because you need your knee. This one, I mean, as long as you have no pain, it doesn't matter really how it looks. That works. Downside of this treatment is, guess what? Nature is not stupid. You burn the nerve, fine. 6 months later, the nerve regrow. And they find their way. And all of a sudden, the pain comes back. How many times can you burn this stuff? I mean, yeah, smart nerve. So that's what they do. But at least it gives you 6 months of relief, and fine. You can keep on doing this, and that's fine. Yes, nerves regenerate. So the best, since we want this joint to stop moving, the best way is to fuse it, to block it. In the past, it was a big deal to do that. And when I say in the past, it's like a few years ago. I mean, it's not like 100 years ago. And in order to block this joint, you have to do such a big operation that basically the operation was a bigger problem than the sacroiliac problem. So I would say almost nobody except one guy in the city were doing this type of operation. Everybody said he's crazy. Guess what? It was not that crazy. Maybe we were crazy because it works. The only problem was the magnitude of this operation. That's why when this new technology came up a few years ago that allowed us to block this joint without opening the whole body of the person, then it became very attractive. And basically, you can accomplish a complete blockage of this joint just by inserting few rods through the skin. Small incision like this. They do that, it takes 40 minutes, 45 minutes. And the patient can even go home the same day. It's like going to the dentist, a little more, but that's it. So I started getting interested in that. So I contacted the company, At the beginning, I was skeptical. It was like 3 years ago, 3 years ago. I was a little skeptical. But we used to say that people who were doing that in the past were crazy. So all of a sudden, I got trained to become crazy. That was a little strange. So little by little, I get more and more confident. And I started doing my first case, second case, third case. And at the end, I realized that patients were very happy. It's a short procedure. It's less than an hour. So what do we do? I'm not going to go into the detail of the surgery because it's not a surgical talk. But basically, we have a triangular rod, a different length, and we insert it through a small incision, and we measure it during the surgery. We measure what size we need, and we pick the right size, and we put them in there. And this rod is actually, look, if you look at the detail of this rod, it's not smooth. It's not smooth. It's like grainy. Why is it grainy? Because it holds better. And the second thing is the bone around it makes a mistake. Because it's grainy like the bone, all of a sudden the bone thinks, oh, looks like bone, looks like me. And it starts growing and getting together, you know, but it's not bone. So basically what that means is this gets fixed into the bone, included into the bone as if it was bone. And because of this, obviously, the joint cannot move anymore. Overall, the results are very encouraging. Not everybody has a perfect result. But overall, you see at 40 months, the improvement in pain from 7.6 to 2, the scale being from 0 to 10. So what makes the difference? Why this one didn't work and why the other one worked? That's the big question for any surgery. No surgery is 100%. And we always try to get better and better and better and better. And we have to understand why instead, when a patient don't do well, instead of kicking the patient out, saying, "I don't well," I think it's very interesting for ourselves to keep the patient in our system and try to understand why he didn't do well and try to learn from that. And what I've learned, I have probably over the years, maybe 2 patients didn't do well. And you have to understand what the problem is. And I would say, and I've seen patients who had surgery as well, didn't do well, come to me. So I kind of have an idea of why patients don't do well. The first reason I found to explain those guys here don't do well is you did a good operation, but actually you made a mistake. The sacroiliac was not the problem. Because it's so close to the spine, and then you took an MRI of the spine, you realize the patient has a big disc herniation. And you say, well, that was a problem. Obviously, this operation couldn't work. And sometimes you cannot blame the doctors too much because it's very hard sometimes. And sometimes I have a new patient come and I start brainstorming for days and days which one is what. So every once in a while, you can actually treat the wrong joint. And it's not a mistake. It's a very difficult thing to do. That's the first reason. Second reason is that was the right diagnosis, but the procedure was not done perfectly. That's another cause, of course. Like most surgeries, if you don't do well, you don't have a good result. The third reason I've seen is patients who don't follow recommendation. I have one patient who actually had a bilateral sacroiliac, my patient, and the first side went very well. And I told her, after the operation, you don't want to put weight on your leg for 3 weeks, crutches. She said, fine. Okay, she did it. And she did very well. She was happy. She came back a few months later for the second time. And I told her the same thing. And she said, yeah. Okay. So what do you mean, yeah? Yeah, I know. Okay, fine. Guess what? She thought, because she did so well on one side, that actually it was not such a big deal. And I know because she's just happened. It's always like this. She's a friend of a close friend of mine. It's always those patients. I know that 2 days after the surgery, 2 days, I did surgery on Tuesday, on Thursday, she went dancing. She never used the cane. She never did anything because she was confident that the first side was so easy that during dancing, she was I don't know what she was dancing, but whatever. And she felt a severe pain at the site of the operation, so she went back home. Guess what? I saw her, and at the end, one of the rods broke the bone at the site of the insertion. You need to let the bone heal. You cannot just go dancing. Okay? There's so many other days in your life you can go dancing. Why don't you just keep this one quiet? And then I had to reoperate on her. And I don't like to put the blame on the patient. I mean, it's not fair most of the time. But this one, really, I was very mad at her. So, and on. There are other causes. But just to explain why it's not 100%, is because there are many causes. Some are due to the surgeon, some are due to the patient. So 82% still are good. I mean, it's a very good number for a disease for which we had no treatment up to 5 years ago, or whatever. Indication. So this treatment is indicated for sacroiliac joint fusion in the indication that we mentioned before. The risk of the procedure. So far, all the cases I've done, I haven't had any major complication. Only one I had, and it turned out okay, but it was kind of a little bit of a struggle. This was a lady who was very, very big, I mean, more than normal. And obviously, the incision has to be a little larger than normal. But we have to go through the muscle, your butt muscle, in order to get to the bone. And by going through the muscle, a small artery, very small like this, was on the way and started bleeding. Normally, it's not a big deal. When this happened, you just stop it. It takes 1 second. But she was so large, I couldn't find it. So basically, this little thing like this has been bleeding for a little while. But then at the end, it took me an hour, but I stopped it, and she did very well. So that's the only big complication, not big, complication I had. Now, what are the potential complications? Like any surgery, you can have all the complication of anesthesia. That's not different from any other surgery. In terms of the procedure itself, we're still working close to the spine. So we have the nerve. So if you don't put the rod at the right place, you can hit the nerve. You can hit some vessels that are running here. I have severe bleeding. But this is extremely rare. And I'm not even sure in the whole country there have been cases described of severe vascular injury or nerve injury. I'm not sure. But I've never seen any. If you want, you can look at this. And you can pass it around. These are the 3 rods that we insert. So you know what that is. And this is the iliac. This is your butt here. So you go through here, and you do that under X-ray. Of course, you know where you're going. So you can see, you can pass it around. So in summary, if you have back pain, if your back pain is above your pelvis, in the middle of this, forget about this, it's not sacroiliac. If the back pain is very low in your spine, it could be sacroiliac. So be careful, especially if you have an MRI that shows stenosis, disc herniation, because after age 40, everybody has this. So be careful. That might not be the reason of your pain. So always think about this and maybe ask your physician whether it could be sacroiliac instead of back pain. Just know that there's a lot of treatment before surgery. I don't think we operate more than 10% of the patient who has sacroiliac problems. So my part is very small, actually. Most of the people here actually treat this patient more than me. But just know that surgery is an option. If really nothing works and your life is miserable because of sacroiliac, surgery is not such a big deal. It's an hour, 3 weeks of crutches, just like if you break your ankle. And then after that, the results are pretty good.